This recording will go over urinary incontinence. Continence is the control over the time and place of urine elimination and is unique to humans and some domestic animals. Incontinence is an involuntary loss of urine severe enough to cause social or hygienic problems. It is not a normal consequence of aging or childbirth and often is a stigmatizing and an underreported health problem. There are different types of incontinence. Stress incontinence is the most common type. Its main feature is the inability to retain urine when laughing, coughing, sneezing, jogging, or lifting. Patients with stress incontinence cannot tighten the urethra enough to overcome the increased bladder pressure caused by contraction of the detrusor muscle. This is common after childbirth when the pelvic muscles are stretched and weakened. The weakened pelvic floor allows the urethra to move during exertion. If the pelvic muscles are not strengthened, this condition continues. Low estrogen levels after menopause also attribute to stress incontinence. Vaginal, urethral, and pelvic floor muscles become thin and weak without estrogen. Another type of incontinence is urge incontinence. Urge incontinence is the loss of urine for no apparent reason after suddenly feeling the need or urge to urinate. Normally, when the bladder is full, contraction of the smooth muscle fibers of the bladder detrusor muscle signals to the brain that it is time to urinate. Continent adults override that signal and relax the detrusor muscle for the time it takes to locate a toilet. Those who suffer from urge incontinence cannot suppress the signal and have a sudden strong urge to void and can leak large amount of urine at this time. Urge incontinence is also known as overactive bladder. Overflow incontinence occurs when the detrusor muscle fails to contract and the bladder becomes overdistended. This type of incontinence occurs when the bladder has reached its maximum capacity and some urine must leak out to prevent bladder rupture. Functional incontinence is incontinence occurring as a result of factors other than abnormal function of the bladder and urethra. A common factor is the loss of cognitive function in patients with dementia. To maintain continence, an adult must be aware that urination occurs in a socially acceptable place. Patients with dementia may not have that awareness. Incontinence may have temporary or permanent causes. Some causes include surgery, spinal cord injury, brain disorders, disease treatment, and certain drugs. Incontinence is a major health problem. While I don't expect you to know these numbers, just to put it in perspective, as many as 45% of women over the age of 65 report incontinence, and as many as 75% of long-term care residents have incontinence. The risk increases with chronic conditions such as diabetes, stroke, cognitive impairment, and impaired mobility. Incontinence may be underreported because healthcare professionals do not ask patients about urine loss. Do not assume that patients will volunteer the information without specifically being asked. You might want to ask questions such as, do you ever leak water or urine when you don't want to? Do you ever leak water or urine when you cough, sneeze, laugh, or exercise? Do you leak urine on the way to the bathroom? Do you need to use pads, tissues, or cloth in your underwear to catch urine? And you could ask them to respond with always, sometimes, or never to get better information about what's going on with your patient. Assess the abdomen to estimate bladder fullness, rule out palpable hard stool, and evaluate bowel sounds. Ask the patient to cough while wearing a perineal pad to assess for stress incontinence. A wet pad on a forceful cough indicates stress incontinence. For women, inspect the external genitalia to determine whether there is apparent urethral or uterine prolapse, known as cystocele, herniation of the bladder into the vagina, or rectocele, which would be a bulge of the rectum into the bladder. These conditions occur when the pelvic floor muscle weakens. The primary healthcare provider can also do an examination by inserting the 2 fingers into the vagina to assess the strength of these muscles. Describe and document the color, consistency, odor, and amount of any secretions from the genitourinary orifices. The urine stream interruption test, where you ask the patient to voluntarily start and then stop urine flow during voiding at least twice, is another method of determining pelvic floor strength. For men, inspect the urethral meatus for any discharge. A digital rectal examination is performed by the primary healthcare provider on both male and female patients. It provides information about the nerve integrity to the bladder. The examiner determines whether there is a tactile sensation in the anal area by observing whether the rectal sphincter is relaxed or contracted on digital insertion. Because nerve supply to the bladder is similar to nerve supply to the rectum, the presence of tactile sensation and a rectal sphincter that contracts suggests that the nerve supply to the bladder is intact. A urinalysis is useful to rule out urinary tract infection. This test is the first step in the assessment of incontinent patients of any age. The presence of red blood cells, white blood cells, leukocyte esterase, or nitrites is an indication for culturing the urine. Any infection is treated before further assessment of incontinence. Determine the amount of post-void residual urine by using a portable ultrasound. This is when you would have the patient urinate and try to empty their bladder, and then when they're done, you would use the bladder scan or bladder ultrasound machine to see how much urine is left in the bladder. If prescribed, catheterizing the patient immediately after voiding can also be used to assess residual volume. Additional imaging is needed when surgery is being considered. CT is the most useful for locating abnormalities in the kidney and ureters. A voiding cystourethrogram or urodynamic testing may be performed to assess the size, shape, support, and function of the urinary tract system. Several interventions are useful for each type of incontinence in addition to drugs, surgical repair, and nutritional therapy. With appropriate therapy, the patient with stress incontinence is expected to develop continence of urine elimination. Indicators include that the patient rarely or never demonstrates urine leakage between voiding and urine leakage with increased abdominal pressure, such as sneezing, laughing, or lifting. Initial interventions for patients with stress incontinence include keeping a diary and pelvic muscle exercises. Surgery also may be an option if other interventions are not effective. Explain the purpose of using a diary in which the patient records times of urine leakage, activities, and food eaten. The diary is then used by the provider to plan and evaluate interventions. Pelvic muscle exercises, or Kegel exercises, are used to strengthen the muscles of the pelvic floor by doing frequent, systematic, and repeated contractions. Please review Chart 66.3 that reviews patient teaching for pelvic muscle exercises. Nutrition therapy with weight reduction is helpful for obese patients because stress incontinence is made worse with increased abdominal pressure from obesity. Teach the patient to avoid bladder irritants in the diet, such as caffeine, that can contribute to urgency and frequency. Stress the importance of maintaining an adequate fluid intake, especially water. In regards to drug therapy, postmenopausal women may use a topical estrogen to the perineal and vaginal orifice, which will cause an increase in the blood flow and tone of the muscles around the vagina and urethra, thus improving the patient's ability to contract those muscles during times of increased intra-abdominal stress. Vaginal cone weight therapy involves using weighted cones for a pelvic floor muscle workout. By strengthening the pelvic floor muscle, the patient is able to decrease stress incontinence. A pessary is a plastic device, often ring-shaped, that helps hold internal organs in place. It is inserted into the vagina and may help with prolapsed uterus or bladder when this condition is contributing to urinary incontinence. The pessary presses against the wall of the vagina to reposition pelvic organs. Urethral occlusion devices can be helpful for activity-induced intolerance. Electrical stimulation with either an intravaginal or an intrarectal electrical stimulation device is available to treat both urge and stress incontinence. Treatment consists of stimulating sensory nerves to decrease the sensation of urgency. It is done as an office-based procedure 1 to 3 times weekly for 6 to 8 weeks. Magnetic resonance therapy involves targeted urinary tract nerve and muscles for depolarization. The patient sits on a chair containing a magnetic device that induces depolarization and helps reduce stress-induced incontinence, similar to drug-induced relaxation of muscles and nerves. Stress incontinence may be treated by a surgical sling or bladder suspension procedure. A sling procedure creates a sling around the bladder neck and the urethra using strips of body tissue or synthetic mesh. Bladder suspension is more extensive, and the surgeon sutures tissue near the bladder neck to a pubic bone to a pubic bone ligament to provide support and prevent sagging. A third surgical procedure is the injection of a balking agent into the urethral wall that provides resistance to urine outflow. In terms of post-op care, after surgery, assess for and intervene to prevent or detect complications. For prevention of movement or traction of the bladder neck, secure the urethral catheter with tape or tube holder. If a suprapubic catheter is used instead of a urethral catheter, monitor the dressing for urine leakage or other drainage. Catheters are usually in place until the patient can urinate easily and has a residual urine volume of less than 50 mL after voiding. The patient with urge urinary incontinence is expected to use techniques to prevent or manage uncontrolled urine elimination. Indicators include that the patient often or consistently demonstrates response to urge in a timely manner, they get to the toilet between urge and passage of urine, and they avoid substances that stimulate the bladder, such as caffeine or alcohol. Interventions for patients with urge incontinence or overactive bladder are non-surgical. These include bladder training and drug therapy if bladder training is not successful. Neuromodulation therapy, which involves the stimulation of nerves to the bladder, can be used to manage urge incontinence. In regards to drug therapy, because the hypertonic bladder contracts involuntarily in the patient with urge incontinence, drugs that relax the smooth muscle and increase the bladder's capacity are prescribed. The most commonly prescribed drugs are anticholinergics because they target specific receptors in the cholinergic family of receptors. Your prototype anticholinergics that you need to know, and again, the anticholinergics work by suppressing involuntary bladder contraction and increasing bladder capacity, are oxybutynin and tolterodine. The beta-adrenergic agonist mirabegron works to relax the detrusor smooth muscle to increase bladder capacity and urine storage. Another drug therapy for urge incontinence is onabotulinum toxin A, also known as Botox. This drug is injected during cystoscopy into multiple areas of the detrusor muscle of the bladder. This treatment relaxes the detrusor muscle and relieves the urge to urinate. Side effects may include urinary retention, painful urination, and an increased incidence of urinary tract infections. Teach the patient to avoid foods that irritate the bladder, such as caffeine and alcohol. Spacing fluids at regular intervals throughout the day and limiting fluids after dinner hour help avoid fluid overload on the bladder and allow urine to collect at a steady pace. Remind patients that maintaining an ideal body weight helps avoid the pressure that abdominal fat places on pelvic organs, thus reducing incontinence. Bladder training, sometimes called behavioral training for incontinence, includes the interventions listed in Chart 66.5 in electrical stimulation. Bladder training involves a great deal of patient participation, provide ongoing encouragement, clarification, and support to increase the effectiveness of all interventions. Start a schedule for voiding, beginning with the longest interval that is comfortable for the patient, even if the interval is only 30 minutes. Instruct the patient to void every 30 minutes and to ignore any urge to urinate before the set intervals. Once he or she is comfortable with the starting schedule, increase the interval by 15 to 30 minutes. As the interval increases, the bladder gradually tolerates more volume. Teach him or her relaxation and distraction techniques to maximize success in the retraining. Habit training and scheduled toileting is a type of bladder training that is successful in reducing incontinence in cognitively impaired patients. To use habit training, caregivers help the patient void at specific times, such as every 2 hours on the even hours. The goal is to get the patient to the toilet before incontinence occurs, thus reducing incontinence. Habit training is undermined when absorbent briefs are used in place of timed toileting. Do not tell patients just to wet the bed. A common cause of falls in healthcare facilities is related to patient efforts to get out of bed unassisted to use the toilet. Pelvic muscle exercises for urge incontinence is helpful and is taught in the same ways for stress incontinence. Improved urethral resistance helps the patient overcome abnormal detrusor contractions long enough to get to the toilet. Please review Chart 66.5, Bladder Training and Habit Training to Reduce Urinary Incontinence on your own.